Hi friends, hope you guys doing good and revising well for your NEET exam. I know with exam nearing you guys would be anxious, but trust me, that's a normal process. Believe in yourself and I'm sure you will be doing very well in your exam. So in this video we shall be discussing your few important questions that have been asked from your GI section in your NEET. Usually you have around 5 to 6 questions that have been asked in your paper. There were around 5 questions in your NEET 2021 and 5 questions also in NEET 2022. So without wasting time, let's begin our discussion, and this would be your last and the final session before your NEET exam. So we have the first question. The 11-month was brought to the ER with the pain abdomen, multiple episodes of vomiting. On examination, you find a mass palpable in your right lumbar region. The barium enema image is given. What will be your diagnosis? So if you look at the barium enema image, they are shown you the claw sign. So this claw sign is classical of your intussusception. So what is intussusception? It is telescoping of one part of gut into another. The most common type of your intussusception is ileocolic. Then your most common type found in children is also your ileocolic, and then the most common type seen in adults is your colocolic, and the most common age group is affected is your infants. So it usually presents with your clinical features of your interabdominal pain, mucus stool, red currant jelly stool, and there would be distension, obstipation and constipation. They usually have a sausage shaped mass in your left upper quadrant, which is conventionally towards your umbilicus. They do not move down with respiration, have an empty right iliac fossa, which is known as your sign of dance, and it contracts under your palpating finger. So these are your few classical clinical features that are associated with your intussusception. And then on baby drawing up legs and crying, they have normal between the episodes. So on the investigation on USG, you can see a target sign, a bull's eye sign, a halo sign, and on barium you could see the coil sign and the claw sign, and the investigation of choice would be CECT whole abdomen. Now the various other options that were given in your exam were your volvulus. So a typical volvulus would be looking like this, and volvulus would be much more common in your elderly age group, and the various sign would include your in X-ray, an apex towards the right upper quadrant, 2 air fluid level, omega sign, a bent inner tube sign, coffee bean sign, and formaldehyde sign that will be seen on your X-ray. And on your barium you would be able to see a bird beak sign, a bird of prey sign, and an ace of spade. And on CT scan you will be able to see a whirlpool sign. Then another question that is frequently asked is regarding your duodenal atresia. So over there you will be able to see your double bubble sign. So these are your few of the classical images from your pediatric GI surgery that are commonly asked in your exam. So now moving down to the next question, we have a 30-year-old presents with your painful and recurrent lesion in your perianal area with discharge. So you have this image which was given, and what is your diagnosis? So this was a clear-cut simple case of your fistula in ano. So now let's take a look at some of the important points with respect to your fistula in ano. So in fistula in ano, one of the most important questions that is asked is regarding your classification. So your classification is your Parkes classification, which classifies the fistula in ano in the following types, which is intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. So the most common type is your intersphincteric fistula, right? And then there's another classification which is given by your American Gastroenterology Association, which classify it into a simple fistula or a complex fistula, right? So your complex fistula would include your anal stricture, anovaginal fistula, extra suprasphincteric tract, and it should be high. Now a recent question that was asked in your NB conducted exam of FMGE was the gold standard investigation. So gold standard investigation is your MRI, and then this question has yet not been asked, but has the potential to be asked regarding your Gutzall's rule. So it is the fistula with an external opening anterior to the plane passing transversely through the center of anus will follow a straight radial course, whereas the fistula with the opening posterior will follow a curved course. So this is the image depicting your Goodsall's rule. And regarding your treatment, we have your Shetton treatment, then you have your fistulotomy. So this is an image which is showing your fistulotomy procedure. I would ask you all to remember these images because they have a recent trend in asking you the operative image procedure. And then you have another procedure which is called your ligation of tract or the mucosal advancement flap or the lift procedure. So lift is the ligation of your interfistular tract. So this is your depiction of your ligation interfistular tract. So this were your few important questions that were asked that can be asked with respect to your anal fistula. So now moving down to the next question. So this is one of the favorite topic of your examiners. A patient presents with acute onset severe pain abdomen. He is hemodynamically stable. Your chest X-ray image is given, and what is your next step? So the chest X-ray image given was of that of free gas under the diaphragm. Now we all know the management for it would include your resuscitation and your laparotomy. So let's take a look at some of the important points with respect to your free gas under the diaphragm. So the free gas under the diaphragm usually presents in your perforated peptic ulcer. So they will have your classical severe pain in abdomen and they may present with features of shock. So your clinical examination, on your abdominal examination, you would find features of peritonitis like in form of a cardboard rigidity, rebound tenderness and guarding. And your treatment would include your resuscitation, exploratory laparotomy where you would go for a gram patch closure and a peritoneal lavage. So these are your few important points with respect to your free gas under the diaphragm. Now moving down to the next question. So 54-year-old female comes to your emergency with pain abdomen, bilious vomiting, history of abdominal hysterectomy 2 years back. Now, so this was one of the confusion lines which was given in your questions because of the options as we come across. So on examination you have your hyperperistaltic bowel sounds and investigation shows your air within your biliary tree. So here you have your answer as your gallstone ileus. Now diverticulitis and ischemic enterocolitis are absolutely ruled out as there are no such symptoms suggestive of your diverticulitis or your ischemic enterocolitis. Now your adhesive intestinal obstruction could have been a possibility with your with the history given of your history of abdominal hysterectomy. But if you look at the other points given in your question over here where shows the air within the biliary tree, so this would not be classically seen in your adhesive intestinal obstruction. So they are basically talking over here about your regular triad which is your classical to your gallstone ileus. So what do you find in your regular triad? You have air within the biliary tree, then you have your multiple air fluid level. So this multiple air fluid level is suggestive of with the finding given to you on examination your hyperperistaltic bowel sound which is suggestive of your intestinal obstruction, and your another component is your stone in your ileum. Right. So usually in your gallstone ileus, cholecystectomy is never done in the same setting. You obviously relieve your obstruction and cholecystectomy is usually done at a later date because such patients usually present to you with a hemodynamically instability. But if your condition permits, in very rare cases you might do the operation in the same setting, but usually it is not recommended. So for your exams you guys can remember that cholecystectomy is not done in the same setting usually. So this was with respect to your gallstone ileus. Now we come down to the next question. So a patient underwent cholecystectomy for gallstones 2 years ago. Now is presenting with the symptoms of your obstructive jaundice. So investigation reveals your stone in CBD. So your stone is likely to be your primary, secondary, tertiary or recurrent. So what are your primary stones? Primary stones are those which are formed de novo in your CBD, and secondary are those which are formed in your gallbladder and they migrate to your CBD. We don't have anything as called as tertiary stone, rather there are residual stones which are seen in less than 2 years of your GB operation Now recurrent stones are those stones which are found after more than 2 years of your operation. So this is your cutoff to classify your residual and your recurrent. So over here they are asked for gallstone disease 2 years ago, that is they are asking after 2 years, so your answer would have been your recurrent stone. Now the next question, a patient with rectal prolapse underwent a surgery. So the image of the surgery was given, so this is the image, and then asked to identify the procedure. So the question was a straightforward question asking you regarding your Thiersch wiring. Now since they have asked regarding Thiersch wiring, let's take a look at some of the important points of your rectal prolapse and the various other operative image procedures. So rectal prolapse are of two types, that is your mucosal prolapse and full thickness rectal prolapse. In rectal prolapse you have only mucosa, whereas in full thickness rectal prolapse you have all the layers including your mucosa plus submucosa. The mucosal prolapse usually is much seen common in children, usually occurs after an episode of a diarrhea or a loss of weight or fat, and they are associated with your cystic fibrosis and Hirschsprung disease and rectal polyps. Now in case of your adult, it is usually associated with your third degree hemorrhoid. On the other hand, your full thickness rectal prolapse usually begins as your intersusception of your rectum, and it starts at the anterior wall of the rectum since the supporting tissues over here at the weakest. So if you look over here, this is your example of your full thickness rectal prolapse, and on the other hand this is your example of your mucohemorrhoidal prolapse of the anorectum. So the treatment for your full thickness rectal prolapse could be either a pelvic versus an abdominal procedure. Now pelvic procedures are usually easy, less time consuming, but have a more increased recurrence rate. On the other hand, your abdominal procedures are difficult, takes much more time, and they are having a less recurrence rate compared to your pelvic procedures. Now pelvic procedures are usually reserved for your old patients and those who are not fit for surgery, whereas abdominal procedures are usually done in your young and fit patient. So if you look at the examples, the Thiersch wiring, Delorme procedures and the perineal rectosigmoidectomy are your examples of your pelvic procedures, whereas resection rectopexy or your suture rectopexy, which is also known as Goldberg, are your examples of your abdominal procedure. So if you look at this image, so if you look see over here, this is your Delorme procedure. So you can see over here the mucosa is stripped of the muscular gut tube. Over here you can see this is the mucosa, so they are stripped of the gut tube, and then the interrupted sutures are used to placate your muscular gut tube. So this is your Delorme procedure, high probability that it can be asked in your next exam. And then we have this showing your Altineus procedure, where you have a full thickness resection followed by a Hansen coloanal anastomosis. And then one image of your abdominal procedures, where you have your rectum being fixed and then a mesh being placed and a suture rectopexy being done, right? So this was a mesh rectopexy being done. So this is your abdominal procedure for your rectal prolapse. Now the next question that we have is the metabolic abnormality in pyloric stenosis: hypochloremic hypokalemic acidosis, hypochloremic hypokalemic alkalosis, hypochloremic hyperkalemic alkalosis, hypochloremic hypokalemic acidosis. So this is a very favorite and the hotshot topic that is usually asked in your exam. So the answer is your hypochloremic hypokalemic alkalosis. So let's take a look at the few points of your metabolic of your pyloric stenosis. So your patients of your infantile hypertrophic pyloric stenosis will present to you with non-bilious vomiting, usually at 2 to 2 weeks. They're different from your infective causes, like your postprandial hunger is one of the most common thing that is seen in your infantile hypertrophic pyloric stenosis. And once vomiting starts, the frequency and the forcefulness increases daily. In GORD, which is a differential diagnosis, you will find that the vomiting waxes and wanes. So incidence is around 1 in 3000, much more common in male compared to your females. And in your test feed, you have your gastric peristalsis that moves from your left to right. And in a feeding baby, that is a relaxed baby, you would find an olive mass in your right upper quadrant. So in the beginning of the video, we had discussed regarding a sausage shaped mass that was seen in your intersusception. So these are some of the classical clinical clues that will help you to differential diagnose the various diseases. And the metabolic abnormality, that is your hypokalemic hypochloremic metabolic alkalosis, and you have your correction done in form of a 0.9% saline with 0.15% KCl in 5% increasing glucose at a rate of 6 to 7.5 ml per kg per hour, and you have your treatment, that is a surgical treatment in form of your Ramsted's pyeloromyotomy. So this were the few questions that we wanted to discuss with you, and now all the best for your exams, and I'm sure you guys will do well. If you have any doubts, you can drop in an email at any point at this email ID, that is ayushkeshav99@gmail.com. So all the best and see you on the other side. Take care. Bye bye.